And once again, everybody, welcome and thank you for joining us here. This is our fourth in this series of 2022 research webinars that we are conducting. We have a fantastic presentation today by Dr. Leo Trasande. But first, Dr. Travis Cabali is going to give us some program announcements, and our Senior Medical Officer, Dr. Christy Anderson, will also be speaking as well before we get to our presentation. So with that, I will turn it over to Dr. Travis Cabali. Travis?
Thank you very much, Rhonda, and welcome everybody. Just a couple of quick updates. First, from the grants office, it's anticipated that the PIs will receive a status notification for the 2022 grant applications by mid to late May. Also, the grants office has all of the Type 5 renewals, and review is underway and ongoing by the grants office. Another announcement, and this is mainly for PIs or statisticians that are assigned to various projects, and it involves the NIOSH Life Table Analysis System. For those of you that might not be familiar with that, that's a well-used software tool to analyze groups or cohorts of people who are followed over time to determine disease incidence and mortality, to see if it's higher than expected. And so for a lot of the World Trade Center studies, this has been used. However, it is being phased out. Dr. Daniels and some of the NIOSH research statisticians are announcing that they have an R code that is replacing LTASC, and it is now available as an R package, and it's available for those of you all that are familiar with this on the CRAN website, which is the Comprehensive R Archive Network, where all updated code is located. Now, Rhonda and Dr. Daniels have scheduled an online demonstration, and a notification has been sent. It's a webinar that's scheduled for May 16th at 2 p.m. If you haven't gotten that notice and you're interested in this, please let Rhonda know. So with that, I want to hand it over to Dr. Anderson. We're just delighted to welcome today's presenter, Dr. Leo Trasande, and I turn it over, Christy, to you. Thank you.
Thanks, Travis, and thanks for giving me the honor of presenting Dr. Trasande. There's been scientific evidence which has emerged over the past 20 years that suggests pre-pregnancy and prenatal exposure to toxic environmental agents can have lasting effects on reproductive health and childhood development. As an OBGYN, much of the time I spend with my patients in their preconceptional counseling or their prenatal visits involves risk reduction counseling towards exposures known or considered to be potentially toxic to the developing fetus. These include topics such as nutrition and diet, including fish, caffeine consumption, tobacco, alcohol, and illicit substance abuse, prescription medication and over-the-counter drugs, and air quality. However, there are many questions I can't adequately answer or effectively answer, and it's frustrating for both patients and providers alike. The evidence that connects some exposures to the effects on pregnancy and fetal health is limited, and more research is needed to explore the gaps in and the questions remaining around environmental exposures, so we can better develop, guide, and refine recommendations for effective clinical interventions. It's one of the reasons the World Trade Center Health Program has this remarkable support for the important work Dr. Trasande is doing. Dr. Leonardo Trasande is a professor for pediatrics in the Department of Pediatrics at the NYU Grossman School of Medicine. He also holds positions in the Department of Environmental Health and the Department of Population Health at NYU. He also leads one of 35 centers across the country as part of the NIH Environmental Influences on Child Health Outcomes program. His research focuses on the impact of the environment on children's health and has looked specifically at the role of environmental exposures in the development of childhood obesity and cardiovascular risks, as well as the impact of chemical exposures and dietary contaminants on postnatal growth and renal disease risk. His work as a principal investigator for the World Trade Center Health Program involves researching the neurodevelopment, cardiometabolic, and respiratory profiles of children exposed in utero to the 9/11 disaster. We are really excited to hear about that work today. And with that, I turn it over to Dr. Trasande.
Christy and Travis, thank you so much for the very warm introduction. I would not be doing this without the wonderful partnership of colleagues at the Columbia Mailman School of Public Health. My co-presenter today is Dr. Miranda Spratlen, who is a associate research scientist in environmental health sciences at Columbia. And I'm also privileged to be joined in the audience by Julie Herbstman, my multiple principal investigator in this effort, who's an associate professor in environmental health sciences at Columbia. So without further ado, just a process question. Do you need me to tee up the slides, or would you like to tee up the slides?
It's up to you. It's your preference. I have them here ready if you'd like. Oh, and you got it too.
See my screen? I got it. All right, so I'll jump in. I was just waiting for the cue. Okay, so let me start just with some basic background, which for many in this audience is extremely familiar. So some of the earliest findings in the aftermath of the World Trade Center disaster identified intrauterine growth restriction as an effect. Now, intrauterine growth restriction has long known to have downstream consequences for not only the offspring when they're children, but all the way through adulthood. As described in the Developmental Origins of Health and Disease hypothesis, the late Sir David Barker first described this about large-scale nutritional deprivation, but we now appreciate two things about that hypothesis in the evolution of our understanding, and that is that environmental influences can also cause intrauterine growth restriction and thereby contribute to long-term consequences that span the entire life course, and that subtle disruptions in programming in utero can have profound consequences for later life, beginning, for example, with adiposity as well as adverse neurodevelopment and all the way to cardiovascular risks in later life. So we also appreciate that the World Trade Center disaster is a mixture of social and environmental stress. We know perhaps much more about psychological exposures, as Stephanie Engel and colleagues described early on. We know that they were associated with decrements in head circumference in the offspring. We know less about the chemical exposures that we know to have been widely emitted and be exposures that were substantial for pregnant women. You can make an argument, and I think it's robust, that some 20 years ago, what we knew about these chemicals was much less than what we know now, and arguably what we've accumulated over time from general population studies, that is, studies not exposed to tragedies such as the World Trade Center disaster, that these same chemical exposures can induce serious and profound consequences, particularly in early life, but beyond. So the reality here is that as science has evolved, we have greater understanding of the profundity of these consequences, in particular about chemical exposure that have evolved. Now, we do know some information coming into the study about exposures of pregnant women in the aftermath of the disaster, and there's some good news and there's some bad news. The good news is that we've relatively not seen increases in some exposures, thinking about mercury and brominated flame retardants that are known to be toxic to the developing brains of children by disrupting prenatal thyroid hormone functioning. But then in some of our own work, leveraging matched comparison of the World Trade Center Health Registry subpopulation of children and a matched comparison group, we did find increases in perfluoroalkyl substances as well as dioxins controlled for potential other confounders. And in some of those early studies of children exposed to the disaster who were then at the time adolescents when they were studied, we found increases in adverse cardiometabolic profiles associated with these exposures as measured in their biological samples. Some of the limitations of these studies are familiar to this audience. This was a disaster medicine context, and so the ability to have a true comparison group is always something that's furtive. and difficult to evaluate, particularly the absence of antecedent data. We know that the psychological and chemical profiles can have differential and interacting effects, yet they remain wanting in our understanding of their potential interaction, particularly in World Trade Center exposed populations. And the importance of a study of children exposed in utero, now young adults, is that we start to see early cardiovascular disease as well as other consequences of prenatal exposure start to manifest, such that there could be targeted interventions for prevention and improved clinical care once conditions are identified. So we had the opportunity to leverage two unique populations. One was a Columbia Children's Environmental Health Center cohort that pre-existed and was not designed with the World Trade Center disaster in mind. It was an existing cohort initiative funded by the National Institute of Environmental Health Sciences and the Environmental Protection Agency through a Children's Environmental Health Research Program. And there was also a cohort of children whose mothers were enrolled in the aftermath of the disaster from downtown Manhattan hospitals, allowing us to try to unite those data sources together to evaluate common exposures found in the aftermath of the disaster, try to relate the exposures to psychosocial stress, as well as chemical exposures in relationship to proximity to the disaster, experiences of the disaster, and then to leverage existing longitudinal follow-up that had already been executed through age 7, and to explore the potential long-term follow-up potential in these populations. In the case of the World Trade Center prenatal cohort, we knew this was daunting coming in because these children had not been followed up for nearly a decade at the time that we started the study. So this slide gives you a sense of the temporality of those populations, and you can again see the availability of early life data or early life data with respect to pre-disaster early life exposure data for some of stress and other factors that we could independently evaluate in a way that would help us understand and help us have a true comparison group. And then leveraging the existing follow-up of these cohorts, we were then able to ideally assess the impact of stress and chemical exposures on World Trade Center exposed populations, with implications for understanding of what specific etiologies could be traced to World Trade Center exposures. These are our three scientific aims. We propose to evaluate the effect of psychosocial stress on birth and neurodevelopmental outcomes. We propose to look at polychlorinated biphenyls and brominated flame retardants in relationship to birth outcomes, as well as neurodevelopmental outcomes, and then to look at PFAS exposure in relationship to birth, neurodevelopmental, and cardiometabolic outcomes in the World Trade Center cohort specifically. So with that, I'm going to pass the baton to Dr. Spratlen, who's going to take us through some of the findings that we've been able to accomplish to date in this presentation. Miranda?
Thanks. So I'll jump right into our some of our findings. And I'm starting with our actually most recent publication, because it really is a good overview of aims 1 and 2. So again, aim 1 was to look at WTC related psychosocial stress and neuro and birth outcomes, and then aim 2 was to look at PVDEs and PCBs and both neuro and birth outcomes. And for this study, which was titled Understanding the Role of Persistent Organic Pollutants and Stress and the Association Between Proximity to the World Trade Center Disaster and Birth Outcomes, we focused on birth outcomes because of a previously observed association between the geographical exposure of proximity to the World Trade Center site and reduced birth weight and length that was published back in 2004 by Sally Lederman. And with this study, this most recent study, we wanted to try to understand what was driving this association between geographical WTC exposure and birth outcomes. Was it stress? Was it chemicals? Was it a combination of the two? And previous studies have looked at each of these individual exposures, but no study previously has attempted to try to look at them together and try to disentangle what might be the strongest drivers. So that's kind of A, and then down B is what we evaluated in this study, where we looked at, again, this geographical exposure of proximity to the World Trade Center site and its association with chemical and stress as outcomes, but also as potential mediators in that previously observed association between proximity to the World Trade Center site and birth outcomes. So next, we can go to the next slide. So first, just to explain our chemical exposures, we looked at 17 different chemicals across 3 different chemical groups. They were, as I mentioned, PCBs, PBDEs, but also dioxins. And because there was a large mixture of chemicals, we decided to use principal component analyses to try to look at them all together as a mixture. And what you're seeing in the top right there, that graph are the principal component loadings for those chemicals. And just briefly, it goes from 1 to 4. The first is reflecting lower levels of PCBs. The second is reflecting lower levels of PBDEs. The third is reflecting higher dioxins. And then the fourth is reflecting higher levels of 2 PCBs, 180 and 153. And so that was our chemical exposure and how we looked at it. And then for stress, we used the Perry-D scale, which is a measure of demoralization. And this is a non-specific measure of psychological distress that's been shown to be reliable across ethnic groups. So those were our chemical and stress exposures. And again, we were first wanting to see if there was an association between proximity to the World Trade Center site and these exposures. And for our proximity variables, we used that lived within 2 miles that had been used in the previous study by Lederman. And then we also looked at another exposure variable, which we categorized as lived or worked within 2 miles because it gave us a larger exposure group. And this category was actually associated with PFAS exposure, which I'll get into in a little bit later in the presentation, other studies that we looked at. But what you'll see here in the table underneath that figure is the association that we saw between that geographic exposure variables and both our chemical PCs and demoralization or stress variable. And what we saw was that the results were non-significant for PC1, 2, 4, and demoralization, but we did see a significant association for PC3, which was again reflecting higher dioxins with both of our WTC geographical exposure variables. So living or working or living within 2 miles of the World Trade Center site was associated with higher dioxin levels. Okay, next slide, please. So then moving on to trying to tie in that, again, that association with birth outcomes. We first looked at our exposure variables, our PCs and demoralization with both birth weight and length. And again, we saw only an association between PC3, the higher dioxins, with a reduced birth weight and a reduced birth length. We did not see significant associations with the other exposure variables. So this gave us some indication that that PC3 might be a good candidate as a mediator in this association. And when we then looked at the association between geographical exposure and birth weight, we looked at it before and after adjustment for each of these PCs and demoralization individually. And what the figure down at the bottom here is showing is that it's not too clear, but each color is a different adjustment. And that first one, pink, is just the association between geographical exposure and birth outcomes. What we see is that that negative association is attenuated only when we adjust for PC3 and is no longer significant for birth weight for PC3, but not for any of the other adjustments. And so what our conclusion was that, one, proximity to the World Trade Center disaster was associated with dioxin levels in pregnant women, and also these findings suggest that dioxin specifically may play a mediating role in the previously observed reductions in birth outcomes. And one thing we did note is that you do see, even after we adjust for PC3, the association is still negative, even if not significant for birth weight. So, we're capturing some of the dioxins are capturing some of that association, but they're just, but it's just a partial mediation role here. And I think it really emphasizes the need to try to understand what else is driving that negative association between proximity to the World Trade Center site and these reductions in birth outcomes. And I think one thing we noted in this paper was that it's possible demoralization isn't really capturing the totality of the biological response to stress in this population. There's obviously a lot of measures of stress, and so that might be one aspect. And of course, we're not measuring all the chemicals. And I think this was at least part of the impetus behind what Dr. Trasande will go over in our next steps, in the hopes that our proposal to expand this analysis to analyze on an exposome level, to try to understand or get at a more comprehensive totality of chemical and biological exposures, metabolic. And I think that doing it on that level might help us understand this association a little bit better. So then moving on to aim 3, the rest of the studies were focused on perfluorinated chemicals, these PFAS, and evaluating them in relation to birth, neurodevelopmental, and cardiometabolic outcomes in the World Trade Center cohort. And just a quick background on PFAS. They're a synthetic subgroup of organic compounds known for oil and water repelling properties, and they've had widespread use as surfactant and stain-resistant coatings on numerous products, and also notably for this population in firefighting foams. They've been associated with increases in many health outcomes, including increases in lipid and liver enzymes, cancer, immune suppression, thyroid disorders. They've also been shown to cross the placental barrier in humans and have been associated with reductions in fetal growth. And despite all this, few studies have evaluated PFAS in cord blood, just 2 in the US, in US populations. And then finally, among various persistent organic pollutants reported in personnel responding to the World Trade Center disaster, PFAS were higher than nationally representative samples. And then also PFAS have been higher in World Trade Center exposed children compared to a matched comparison group. So this was kind of just, the background behind the interest in looking at PFAS and these different health outcomes, specifically in the World Trade Center cohort. Next slide, please. So, excuse me. Our first study wanted to first look to see if PFAS was PFAS exposure was associated with proximity to the World Trade Center site. And what I'm showing you on the right here is population characteristics by our different PFAS variables. And we're interested in also looking at PFAS by demographics, because as I had mentioned, there really hasn't been much research on PFAS in cord blood. So we were interested in seeing how it varied by demographics. And you can see here that it does differ a bit by compound and also by age, sex, race, BMI, education, and then one of our exposure variables, which I'll be going into more. And these are by very relationships. And then we went into more detail. Next slide, please. With our exposure variable, we ran these multivariable regressions looking at our PFAS compounds with different exposure or geographic exposure metrics, living within 2 miles, working within 2 miles, and then living or working within 2 miles. And the results from these analyses was that PFOA was our main finding here. We found a significant increase in PFOA with those living within 2 miles and those living or working within 2 miles of the World Trade Center site. And I think the main conclusion from this study was that PFOA seemed to be the dominant PFAS compound here, and we don't know exactly why, but it could have to do with differential transplacental transfer efficiencies across the compounds. So how a mother is exposed may not translate to how exactly how the fetus is exposed, and PFOA has a more efficient transfer efficiency. That might be one explanation, and then differences in just the sources of the different PFAS compounds at the disaster site. And then the other thing that I think was interesting to note was that the living variable was really more important than working in this analysis, and this was consistent with actually another study that found higher PFAS in children exposed to the World Trade Center relating to home dust versus dust cloud. The home dust was more of an exposure than the dust cloud itself. So just emphasizing the importance of home exposures and dust in the home. And I think on a broader scale of making sure in other disasters that there is an emphasis on cleanup in the homes, not just at the site of the disaster, because there can be continued exposures there. Okay, next slide, please. So then our next paper, we are interested in looking at PFAS and cord lipids, and some of the background behind this. Previous studies have identified significant associations between PFAS exposure and numerous cardiometabolic outcomes, including lipid profiles in adults, children, occupationally exposed groups, and pregnant women. Dyslipidemias, including elevated total serum cholesterol and triglycerides, are well-established risk factors for the development of cardiovascular disease. And findings generally suggest a positive trend between PFAS in both triglycerides and total cholesterol, but the significance of these relationships have varied across compounds and studies. And higher cord lipids have consistently been reported in low birth weight and small for gestational age newborns, both established risk factors for cardiovascular disease in adulthood. However, this is the first study to evaluate PFAS exposure and cord lipids. So a focus on cord blood. Next, please. So what I'm showing here is our our results looking at, again, our PFAS compounds. So those 5 on the left side: PFOS, PFOA, PFNA, PFHXS, and PFDS. And we saw pretty consistent associations across these variables and our lipid outcomes. So significant associations for PFOS and total lipids, PFOA, total lipids and triglycerides, PFHXS, total lipids and triglycerides, and then for PFDS and total cholesterol. And so the evidence here is that is consistent with what we did expect to find, that higher PFAS are associated with higher lipids, and this is consistent in the cord blood. And one of our novel findings was for PFDS, which is an understudied compound. Again, we're seeing, even at quite low levels, we're seeing a significant positive association with total cholesterol. And yeah, I think that's it for that slide. Next slide, please. Okay, so then moving on to PFAS exposure and cognitive outcomes. A little background on this relationship. As I think everyone knows, the development during the prenatal period is particularly vulnerable to neurotoxic exposures because of the rapid and fundamental developmental processes that occur during this time. And the evaluation of the relationship between prenatal PFAS exposure and cognitive outcomes in humans and animals is understudied, and findings have been quite inconsistent. So, oh, can we go back? Sorry. Yeah, perfect. So we looked at, in this study, we looked at neurodevelopment measured at 1, 2, and 3 years using the Bailey scales of infant development. These 2 subscales are MDI, Mental Development Index, and PDI, Psychomotor Development Index. And then at 4 and 6 years, we used the Wechsler Preschool and Primary Scale of Intelligence. Excuse me. And the 3 subscales here are performance or per IQ, VER or verbal IQ, and full or full IQ. Next, please. And what I'm showing here is just the findings for PFOS, because I think there's not enough room to go over everything. And I think it gives a good kind of reflection of the variability that we saw. So we didn't look at these in mixed models. We looked at them separately by year because they did differ each year, as you can see. And we also looked at it by gender. So in pink, we have the overall relationship, and then in turquoise is for females, and for blue, and in blue, we have the male associations, and we're looking at, you know, the different outcomes at each year on the bottom, you can see, and each scale. So 1, 2, 3, and then 4 and 6. And although it did differ, there were some trends. We generally saw higher MDI that was measured at 1, 2, and 3 years, higher MDI scores with higher PFAS exposure. And that reached significance for at 3 years for PFOA, PFHXS, and for our summary measure of higher overall PFAS exposure, we again did principal components, and that PC1 was reflecting higher overall PFAS exposure. So we did see and you can see that a little bit here for PFOS too, even though it didn't reach significance at MDI, the MDI at years 2 and 3. And we also saw that actually at years 6 as well. The other trend that we noticed was sex-specific relationships between PFAS and cognition, with results suggesting that higher PFAS may be associated with higher scores for some measure cognition among females, but not males. And again, we can see this a bit in this figure where the turquoise is female, and for several of the measures, you can see that it's higher. The relationship is positive for females, and either more null or negative for males. And there was a significant interaction for sex for PFAS at that MDI2 variable, which you can see in the figure as well. And then finally, with our principal component analyses, it provided some evidence of divergent neurotoxic findings across the PFAS compounds, with some positive associations for PFOA and PFHX-S, but negative for PFNA for certain outcomes. And I think really the conclusion from this, even though it was a bit complicated, is that I think really there needs to be more research looking at PFAS and cognition, because it's consistent in a way with previous studies, in that previous studies have also found very inconsistent results with some positive or protective seeming effects. And I think before we jump to think that PFAS could potentially be protective in some ways, there definitely needs to be some more research into that to try to understand what might be going on. And so definitely, and I think in larger sample sizes too would be really helpful. Okay, next slide, please. And then our last study here hasn't been published yet, but we are looking at chemical mixtures again. We're looking PBDs, PCBs, PFAS, and dioxins all together, and childhood obesity measured at ages 1 through 7. Next slide, please. And on the left is just a correlation matrix of BMI Z-scores from ages 1 through 7 and our chemicals, and really just to show that there were positive and negative associations, and none of them were very strong. And that was reflected in our multivariable regressions, where we looked at each of those chemical groups as mixtures. And I'm just showing the associations for PC1, which is reflecting higher levels of each chemical in that group, and their association with BMI Z-scores from age 1 to 7 in mixed models. And you can see here that there's no strong associations there, and nothing significant. So we didn't see any significant associations here, but I think we'll still plan to write this up. And I think it's not to say that there won't, there may, these associations may not have emerged yet by age 7. And I think I'm going to be passing this back off to Dr. Trasande, who will go into the adolescent work. And, there's been some challenges with that data, but hopefully we'll be able to look to see if some trends emerge as the children age into adolescence.
Thanks, Miranda. So we clearly want to try to follow up this population as much as possible, and particularly because cardiometabolic issues, as I elaborated at the top, do emerge in adolescence and early adulthood and can be targets for intervention. I would say, having said that, the timing of our launching of this study collided not only with the COVID-19 pandemic, but a substantial fluidity and movement of the population, particularly as adolescents age into being their own consenters for research. And this is where we've known for a long time, there are some families that don't even want to think about 9/11 because they don't want to re-experience the trauma associated with the event, not to mention other factors that can get in the way. So in parallel, what we've been doing is to explore some other measures, a deeper, untargeted, generally speaking, approach to exposure assessment that allow us a few benefits. One is to really get even a broader, comprehensive sense of the mixture of chemicals to which pregnant women and their children were exposed to in the aftermath of the disaster, and look at biological responses that were not measurable in some cases until very recently, with unprecedented advances in metabolomic, using liquid chromatography linked it to high-resolution mass spectrometry, as well as exposomic assays, the latter of which uses gas chromatography linked to high-resolution mass spectrometry. And so our hope in this effort is to provide some insight into etiologic pathways and to allow us the opportunity to look at causality of relationships between prenatal exposure and latent disease risk. Our other hope is potentially to be able to identify markers that could be studied in populations without antecedent historical data about their exact location or proximity to the World Trade Center disaster, with a hope towards being able to identify chemical signatures that may persist in a long latency in a way that then they can be related to disease outcomes as well. So within that context, I have the privilege of presenting some preliminary studies here. These are on a modest subsample of mothers who were exposed to the World Trade Center dust in the World Trade Center Columbia cohort, comparing them to unexposed mothers. And what we found right away were a number of spectral features confirming some of our own earlier findings, but identifying a broader panoply of metabolites associated with PFOS, PFOA, and 3 different dioxins, with substantially clear differences between exposed and unexposed, suggesting potential signatures that could even be more attractive from a statistical perspective in comprehensively looking at exposure clusters in a way and differentiating groups, both in relationship to self-report questionnaire as well as physical health endpoints in those populations. And these, I'm also hopeful, will be helpful not just for the child health part of the World Trade Center portfolio, but other subpopulations in the portfolio. We also started to explore in greater depth some of the mechanistic insights behind some of the dyslipidemia that we've seen in relationship to particularly PFAS exposure that's higher in 9/11 exposed pregnant women and their children. And in here, we already saw some early findings suggesting disruption of fatty acid synthesis as well as steroid hormone biosynthesis, not to mention the carnitine shuttle that was also clustering within the children with higher core triglyceride levels. And these enrichments will allow us the opportunity to explore in greater depth, not just mechanistic insights, but to potentially translate that out to other populations in which exposure to the disaster is known, and seeing if there is reproducibility and consistency across different contexts with different degrees of exposure and outcome data. So I hope this is a helpful overview of a broad array of work that's included a number of partners, not to mention the collaborators identified here. And I'm going to stop sharing screen and look forward to your questions and comments.
Well, Dr. Trasande, we are very grateful that you and Dr. Spratlen took some time to present your findings and your information. So thank you so much. people. And many thanks to all of you for attending. We'll see you next month. Thanks, everybody.